Awesome. All right. Tonight we have Dr. Caroline Gorn with us here from Mercy. She's an endometriosis specialist. So we're so happy to have her here with us during Endometriosis Awareness Month. So thank you, Dr. Gorn, for joining us.
Thanks for having me.
Yeah. Anything else you want to add about, patients that you see or areas of interest?
So no, I did training in minimally invasive surgery, which often ends up being the type of doctors that treat endometriosis. So we see a lot of it in our practice, thankfully, because there aren't a whole lot of other doctors that treat this disease, which I'm sure we'll get into.
Yeah. Awesome. Thank you so much. So our first question is, it typically takes many years for a client to receive a diagnosis for endo. Can you help educate our listeners about their options for diagnosis and then also understand why it's such a long process?
Definitely. So this is a statistic that I think is probably changing, but the old statistic that we used to give was it takes about 8 years and over 3 healthcare providers to diagnose endometriosis. This is for a few reasons. One, I think there hasn't been a whole lot of education or teaching from the medical field for providers on this condition. And I think women have always been told your period is supposed to be terrible. So when women complain of painful periods or dysmenorrhea, it's just supposed to be normal. And we're finally starting to wake up and listen to women and realize, the dysfunction that's caused, the lack of ability to function in normal, activities is just not normal, and we need to do something about it. So finally, we're starting to see more and more that providers are on the lookout for this. The issue we still have with endometriosis that we haven't quite solved yet is that to officially be diagnosed, most of the time you're going to need surgery with a biopsy. So we can have suspicion based on symptoms, but oftentimes you can't have an official diagnosis without surgery. It's often invisible on ultrasounds or CTs or MRIs. So I think that's also part of the delay is you need to have a physician that's really looking for the specific symptoms of endometriosis and then has a high degree of suspicion.
Yeah, that's super interesting. And I think Dr. Chadwick had said this, one of your partners, before. Endo is the great imitator, right? So can you kind of speak to some of the different symptoms that people come in with that they think, is something else, but actually is endometriosis?
Definitely. So I would say the most common 3 that I look for are painful cycles, pain with intercourse, and actually changes in bowel function with your period. So going off bowel function, many women carry a diagnosis of irritable bowel syndrome, when actually really it's endometriosis all along, and fixing the endometriosis helps improve bowel function. Women also may feel, because of the general inflammation that happens when you have an endometriosis flare-up, many women may feel almost like the period flu, so to speak, run down, exhausted, like they're coming down with an illness, something like that. It can also mimic signs of sciatica, so nerve pain down the back of your leg, depending on where it's sitting. So there are many different ways that it can present. So again, you have to have a high degree of suspicion when you're taking a history as a provider to even have this on your list of differential diagnoses.
Yeah, and that's part of why I love knowing experts like you, is because when I'm sitting in an evaluation with a patient and I hear these things and my brain kind of goes, that sounds a little suspicious. Let's send that off to somebody who knows more than I do.
Right. Well, and that's the importance, right, of having people in the community who may not be gynecologists, a primary care provider, a physical therapist like you, that are listening for these things and, not just fitting it into their box that they know, and knowing when to say, this doesn't fit what I expect. Where can we send you that may help you get your actual diagnosis, rather than fitting somebody in a box, moving on to the next patient when all of it doesn't really fit.
Yeah, 100%. What are the best treatment options for someone with endometriosis?
So there are many, and there's no one size fits all treatment option generally. So it is a hormonally sensitive condition, meaning it responds to the hormones that your body creates. I almost describe it as your hormonal fluctuations around your period and around ovulation are almost like lighter fluid on a fire. The endo's kind of there all the time, lining your pelvis often, and it creates generalized inflammation. It's there always, but you have your flare-ups when you have your hormonal surges. So because it kind of feeds off of the hormonal surges, if we can keep your hormone levels on a more stable basis rather than having these giant fluctuations. We can often manage medically the symptoms. So typically these are going to be types of birth control. There are other types of medications that are not technically birth controls also that may impact hormones that also can help. And then sort of our last management option would be surgical. So surgery is generally laparoscopic, where we go in with small incisions and we find any endometriosis that may be there and remove it. We'll get into this later. I think this is one of your later questions, but adjunctive therapies too. I mean, pelvic floor physical therapy, exercise, a lot of these things will also help treatment wise, but I typically will start with kind of the heavy hitters first with the, the medication options and surgical options A to Z, so that my patient understands that there's a, this is a marathon, not a sprint, essentially.
Yeah. And I think that that's an important thing to point out, because I know that there's like a growing hesitancy with birth control, right? And so having that reminder of, we're just trying to neutralize things, and that's why it's helping, right? So definitely good for people to know. Speaking of, what kind of lifestyle changes are helpful?
So the biggest thing actually we're finding more and more, and actually I just saw a study published within the last month about the importance of exercise when it comes to pelvic pain. I think, well, we know, right, and you even better than I, that when we're in pain, our bodies tense up and things stop moving and working as well. And so reminding our bodies about the motion, not letting things get locked up, is really helpful. Stretching. So I usually will recommend like things like yoga, Pilates, where we're focusing on our pelvic floor. We spend no time in this country taking care of our pelvic floors, and in other countries it's the norm to do it, and we just, that's not a priority here, unfortunately. As I can't tell anybody more than you.
I'm nodding over here. Yeah, 100%.
But the exercise really, we're finding more and more helps both the physical pain, and also there's a lot of anxiety that tends to accompany this pain and depression and that kind of thing. And we also know movement helps with those too. There's also an anti-inflammatory diet that some patients anecdotally feel is very helpful. The science behind it, or the actual research, doesn't wholly support it, but I'll often sort of mention it as, if you want to try and see if it helps you, great. But I typically say, don't let it rule your life. If you're finding it's not helpful, don't, miss going out to dinner with friends because there's nothing on the menu that's in your diet. So those are the two most important things that I mentioned.
Yeah, love it. And that's similar to, I see a lot of people with like bladder pain syndrome. And so, technically, yes, there is a diet for IC, but like it doesn't always work for people. So finding the foods that really flare you can be helpful. Yeah. Great.
Definitely.
And then how does treatment of endometriosis improve infertility, or does it?
Yeah. So that's another thing. So a lot of women actually won't even know that they've got endometriosis until they struggle with fertility, and then that's how they get their diagnosis. So endo, just like Dr. Chadwick had mentioned, we had mentioned earlier, is a great pretender. Sometimes that's how it presents. You've never had pain in your life, or pain that you thought was abnormal, and all of a sudden you struggle to get pregnant. So what we do know, we have good data to support that resection, surgical resection of endometriosis can help with fertility. We know this in the here and now time point. So if you have been trying to get pregnant and been unsuccessful, if we then do resection, often that will improve fertility rates. What we don't know is resection now for fertility in 5 years, if that has any impact. Logically, it would, but we don't have the actual scientific data to support that right now. And we think it's probably based on a couple of different things. One, endometriosis can create adhesions or scar tissue, which impairs the basically travel of the egg through the fallopian tubes, fertilization, all that kind of thing. So from that perspective, restoring the normal anatomy helps. But then also, as I mentioned, the endometriosis causes all this inflammation, and the little oocytes in our ovaries don't love hanging out in that environment. So removing all of that inflammation, resecting it all, can be super helpful.
Yeah. Awesome. And can you dive into kind of the difference between resection and ablation? Because I know that there's oftentimes a lot of questions about that, and there are some people who are still doing ablation. So
Yep. So the way that I was trained, and logically the way it makes sense to me, is, if you actually resect the endometriosis, meaning physically remove it from the body, it should give you longer relief. The reason being is that endometriosis can be very superficial, just living right on the surface of the peritoneum, which is the tissue that lines our abdomens. Sometimes, though, it can be more deeply infiltrating, and that's the kind that grows through the lining and deeper into the muscles, into the nerves. If you ablate, meaning just burn the surface layer, you can't be totally confident that it actually wasn't the deeply infiltrating and that you've gotten all the way to the root of the problem. Mm-hmm. So the unroofing or the resection of the endometriosis allows for removal of all of it. Now, there are some times where ablation would be required. For example, if you've got a superficial implant on an ovary and fertility is still a concern, I wouldn't want to resect a portion or a wedge of the ovary. I would just fulgurate on the ovary. Sometimes if it's in a particularly difficult location, for example, on a uterine artery or somewhere where we really can't safely remove it without causing massive harm to the organ that we're treating, sometimes ablation is required. But generally in my practice, how I was trained and how my partners in the Endometriosis Center at Mercy operate is to excise. And that's an important thing to ask your surgeon if you are considering surgery, is how do you manage it and sort of what's your thought process?
Yeah, definitely. And that's great to know the nuance too, because I just learned something. So good to know. And then who's on the team? You're kind of the head of the team, but who else is on the team for somebody dealing with endometriosis? What does that look like?
Definitely. The team is critical. So when I meet somebody in the office, we talk through like a holistic management plan, because like I said earlier, it's a marathon, it's not a sprint. So we always, if we're going to start off with surgery, for example, we'll start off with a resective surgery. And then we'll talk about typically a hormonal sort of medication moving forward to help prolong the amount of time that somebody goes before they have recurrence, because it is likely most women will have some recurrent symptoms at some point. I will often talk about pelvic floor physical therapy, for example. I send the great majority of my pelvic pain patients to pelvic floor PT. That is critical because there's something called central sensitization, which we're learning more and more about, where even if you've resected the actual inciting factor causing the pain, the nerves, the muscles are still so tense, so activated that your brain's still sending the pain signal. And without that reset, and without strengthening the muscles that need to be strengthening and loosening the ones that are too tight, you're never really going to get that whole relief. Mm-hmm. Also gastroenterology. I send a lot of my patients to GI. Colonoscopies are a big part of the workup. Often, as I mentioned, IBS is a common pre-diagnosis for endometriosis. So often they'll make sure they've got a gastroenterologist and are managing those kind of bowel symptoms too. Primary care providers, if anybody's got, heavier bleeding, maintaining good blood counts, iron infusions, that kind of thing. So certainly a holistic approach. It's rarely ever just me.
Yeah. And that whole team approach is like super critical, right? Like, mm-hmm. like you were mentioning with central sensitization, like having the GI component. And I find like a lot of people need psychotherapy also, right? Like they need somebody to talk through, because this is a huge life change. Mm-hmm. There's, speaking from personal experience, like there's a lot of difficult feelings about your own body that you need to talk through, and so psychotherapy is a huge component of that also. So
definitely.
Yeah. I had two like curiosity questions. Sometimes like if you, do you mind if I go off script a little bit?
Yeah, go right ahead. Yeah.
So I've always wondered, like, if you're in the OR and like, mm-hmm. You end up seeing there's like something sitting on someone's bowel, for example, mm-hmm. are you calling GI? Like, how does that work?
So it depends. With endometriosis, we often kind of expect the unexpected. It's one of those diseases, like I said, we can't really typically see on imaging. So I'll often get in there and have a general sense of what I expect to find, but I've certainly been surprised. So again, it depends. I will always consent a patient for an appendectomy as part of the surgery, because often the appendix can be involved, and typically the appendix has, it has no other function besides to cause problems. And if it's got frank endo on it or looks inflamed or whatever the case may be, we actually do find cases of appendiceal cancer. We have coincidentally found because the appendix looks inflamed or whatever the case may be, and so it'll come out. So typically I can do that myself, but sometimes, and I have had within the last couple of months, actually Dr. Chadwick and I did a case together where this happened. The base of the appendix was completely a nodule of endo right as it joined the large bowel. And so in that case, we had consented for an appendectomy, but it was basically outside of our scope of practice because it required some resection of the large bowel also. And so we did call a general surgeon in to help us there. Otherwise, typically, I would say in my practice, it's pretty rare to find a deeply infiltrating bowel lesion without having any idea that it's going to be there. So typically women with really horrible bowel endo will have had bloody bowel movements with cycles. And so they will have had a colonoscopy in advance. And so we will kind of have an idea that this is going to be the case, and we'll plan to have general surgery there at that time. Otherwise, if it's a really superficial lesion on the bowel, I can just basically shave it off and reinforce the bowel, no problem. But if there really is a true surprise, a true deeply infiltrating bowel lesion, my practice is that I don't want any surprises for the patient generally when they wake up. So what we'll do is we'll resect all of the endo that's everywhere else, leaving the bowel lesion, and then assess their symptoms afterwards, knowing we've left a little bit behind. The reason is because a bowel resection requires a whole other consent. There's post-op recovery, there's stays in the hospital, there's change in bowel functions that can be long-term. And so this is not something I'd want to sign somebody up for if they weren't really, if there's truly a surprise, they weren't really having bowel symptoms in advance. I'm not going to cause more problems with them without having had the whole conversation with general surgery, et cetera. So my practice is if it's superficial and I can remove it, great. If it's truly a surprise, truly deeply infiltrating, we leave it behind, take everything else that we can, and then it's a conversation moving down the line.
Yeah, interesting. And same goes for like urogyne, like if somebody's got like kidney issues or like urology, or ureter, like endo, similar situation.
So ureteral endo, typically we can actually resect. It's rare that it will be deeply infiltrating. I've actually never seen a case or heard of a case where it's actually growing into the ureter. I'm sure that it exists because endo would do something like that. But I've never seen it. What I have seen is endometriosis growing into the bladder. And so in that case, if you need a bladder resection, depending on where it is within the bladder, if it's down where the ureters come in at the bottom of the bladder, that does require urology to come in and resect. If it's towards the top, the dome of the bladder, that's something within our scope as a gynecologist.
That's so fascinating. Thank you.
Yeah.
And then final question here, anything, what's your final thoughts for people? Like if you're dealing with pelvic pain, like what's your advice for somebody trying to navigate this path?
Yeah. So my general sort of rule of thumb is if you feel like something is wrong, if you are being prevented from doing things you want to do, living the life you want to lead because you're in pain, whether it's, painful cycles that take you out of work every single month for a day or two, whether it's, you can't have intercourse with your partner and enjoy it because you're in so much pain, these should prompt you going to a doctor. If you don't already have a gynecologist, talk to your primary care doctor about it. And again, if you have a high degree of suspicion, you should request to see somebody with expertise. There aren't, like I mentioned at the beginning, that many of us that are specializing in endometriosis. And I would really urge women to find a specialist rather than to go to a generalist, because we all do what we do it really well. But sometimes we don't know what we don't know. And so what we don't want to do is have surgery with somebody that's going to do an incomplete resection or incomplete fulguration. And then a year later, your symptoms are back right away. And we're talking about a second surgery. So I would just urge, ask the questions. If you feel like you're not being heard, ask to see somebody else. Do your research online in terms of, specialists that treat conditions that you may be concerned about. And ultimately, it never hurts to have a consult, right? The worst thing that somebody's going to tell you is, I don't think that's consistent with, endometriosis or whatever the case may be. And, and that's it. You've wasted a half an hour of your time. It's not the end of the world, but typically, it's a useful exercise.
Awesome. Thank you so much, Dr. Gorn. And I can't sing your praises enough. Like, I appreciate your expertise and, and all the knowledge that you've shared with us over time, and the patients that we share. I know that they really appreciate you, and you're just a wonderful doctor. So thank you so much.
Well, it's my pleasure. And I thank you, and right back at you, because it's pelvic floor PT is a hard thing to find somebody that really specializes and really cares and does what you do. And I love having the recommendation to send my patients to you guys, because I always know they're going to be in great hands. So, and you guys are all over now, so I can always say, we'll find one that's convenient for you.
Yeah.
So yeah, it's been really nice to have that, solid recommendation. We always look as providers for people that we would recommend wholeheartedly, and your practice and you are always that for us.
Well, thank you so much, Dr. Gorn.
Of course.
Thank you. And thank you so much for joining us. Be on the lookout, everyone, for our newsletter coming up at the end of the month on endometriosis. We'll have a couple of fact sheets, and then also a couple of blogs for you there. And this link will be posted there as well. Thank you so much.
Thank you.
Bye.
Bye.